Hello, I'm Tony Bernardo, Dean of the UCLA Anderson School of Management, and I'd like to welcome you to this event, COVID-19 Leadership Imperatives for Today and Learnings for Tomorrow. This event is hosted by the centers at Anderson. Our centers at Anderson act as hubs for leadership insights, faculty research, student and alumni engagement, and service to our communities and society. They operate in areas such as finance, real estate, entrepreneurship, technology, media and entertainment, marketing analytics, and global issues that transcend borders. The leadership discussion today is part of a series created by our centers, collaborating in an effort to share expertise, learnings, and best practices across all disciplines, and to bring greater awareness of the problems and opportunities in the world around us. Today's discussion is in collaboration with UCLA Health and the Geffen School of Medicine, which have been terrific cross-campus partners for UCLA Anderson. We live in a world today with huge opportunities and challenges in every sector. We see the benefits of technology as an enabler in dealing with challenging issues such as COVID-19. We see changes in the fundamental place of where we shop, how we get health services, how we are educated, and how we are entertained. We see notable best practices from abroad. We see a changing role for government and institutions. And across all areas, we see challenges to leadership that require an ability to conceive of new solutions, new business models, and new ways of engaging with employees and our communities. Tonight's program on the leadership learnings from COVID-19 is a great example of the spirit of collaboration and of this collective effort, brought forward by our centers with UCLA Health and its medical school. I hope you engage in this program, learn from it, and ultimately lead in ways that benefit you, your organizations, our communities, and society at large. Now I'd like to introduce Terry Kramer, Faculty Director of the UCLA Anderson Easton Technology Management Center. Terry will introduce our distinguished speaker today and moderates our program. So Terry, thank you.
Great, Tony, thanks. And let me just add my own welcome to what is a large and diverse audience today. This is the third in our series of leadership discussions in collaboration with the centers at Anderson. And I want to just extend a special thank you to Tony for his own leadership on this series, on the centers at Anderson, and on a focus on a growing and changing nature of leadership. One that is a lot more interdisciplinary in nature, one that has to contemplate a growing set of stakeholders and serve those stakeholders, including community and society. Now for the program, what I'd like to do is first start with a bit of context on COVID-19 globally and here in the US. I'd like to talk about the key areas of focus of tonight's program, and then I'd like to provide a detailed introduction to our guest speaker. So first of all, let me just start out with some of the latest statistics on COVID-19 to frame the issue. When you look globally, there are now more than 27 million cases of COVID-19 and more than 900,000 deaths. In the US, the results on a proportionate basis are even more distressing. In the US now, there are more than 6 million cases of COVID-19, which represents about 22% of the world's COVID cases, even though the US only has about 4% of the world's population. And a similar story on the deaths here in the US, about 190,000 deaths, which represents about 21% of all deaths, even though the US only represents, again, about 4% of the world's population. Now, we're very fortunate here at UCLA to have a world-class health center and medical school, which has been at the epicenter of COVID-19, which has had an opportunity to have a bird's eye view about the pandemic, about its causes, about research, institutional responses, and ultimately implications for patient care and public health. And all of this then brings us to the fascinating issue about leadership here. What does effective leadership look like in this context? Now, when we think about leadership, when we think about leaders developing strategy, we often think that the most important beginning step is to understand context. And the question here is, has that context been fully understood, and what are the learnings? We also think of the importance in leadership of being fact-oriented and data-oriented in driving strategy. What have been the learnings there? We often think about the role of technology and what's the role of technology? What have been the learnings there? And in many cases, leaders are dealt with bad circumstances. And in those situations, we often think of leaders needing to do a lot of best practice sharing, to learn from elsewhere to drive effective strategy. So in tonight's program, we're going to look at all of these leadership issues. We're going to look at the role of data in science in understanding the problem and effective solutions. We're going to look at the role of technology. We're going to look at the role of institutions here, whether that be healthcare providers, whether that be government, academia, businesses, or individuals. And we'll look at the role of culture and human behavior in driving desired actions and outcomes. Now, I can't think of a better speaker than UCLA's own Dr. John Mazziotta. He's been Vice Chancellor of UCLA Health Sciences and CEO of UCLA Health since 2015. He's been a member of the David Geffen School of Medicine faculty since 1983. He's also been Dean of the medical school. In addition, he was chair of the Department of Neurology and founding director of the Amundsen Lovelace Brain Mapping Center. He earned his MD and PhD in neuroanatomy and computer science from Georgetown. And following an internship at Georgetown, he completed his neurology and nuclear medicine training at UCLA. He's published more than 260 research papers and 8 texts. He's received numerous awards and honors, including the Oldendorf Award from the American Society of Neuroimaging. He's been elected to the National Academy of Medicine and the Royal College of Physicians. Now, for the format of tonight's program, I'll ask a series of questions of Dr. Mazziotta that hopefully will allow us to better understand the issues, better understand his views and recommendations. And then we'll use Slido for a moderated Q&A. So the Slido event code is 69710. So you just go on to slido.com, SLIDO.com, enter the event code 69710. You can either enter in your own question or you can upvote one of the existing questions, and I'll endeavor to ask the most popular questions. So Dr. Mazziotta, a big welcome and thank you for being with us.
Well, thank you, Terry and Tony. I appreciate it. I appreciate the opportunity, the invitation, and also all the help we received from the Anderson School throughout the pandemic, especially in the early stages with logistics, operation, decision support. Very helpful and very unique to our experience. Thank you.
Well, it's a great partnership and I think a good living example of the interdisciplinary nature of problem solving. Dr. Mazziotta, let's start at the most macro level here and probably the most timely level. Can you give us your own view about where do we stand today on COVID-19 and how concerned are you with the current state?
Yeah, well, I'm quite concerned. You read the numbers, and this is a serious, fatal illness. It's fortunately not fatal in but a small fraction of the individuals who contract it, but it's an illness that has no real effective treatment that halts the illness, and we have no vaccine. And we're also entering the flu season now, which will further stress the capacities of the hospitals throughout the world and the ones in the United States in the Northern Hemisphere in this next 5 months or so. But we have seen, and the public has had a chance to observe firsthand, that public health measures work. So if members of society follow those rules and government officials enforce them, it is a manageable illness through prevention and minimizing surges. Fortunately, the social distancing and masking and the other features that are in place worldwide demonstrate that in the Southern Hemisphere, it looks as if the flu is not as prevalent as it might be in a typical year, which makes sense. If you protect yourself from the COVID-19 virus, you're also going to be protected from whatever the flu virus is in this particular season. So Yes, I'm concerned. We're ever vigilant about surges, and you've seen the sequence of how that works. But we're also learning how to manage through this and use public health measures despite not having specific treatments or a vaccine.
Mhm. And Dr. Mazziotta, can you zoom in now on UCLA and UCLA Health? You obviously have got an incredible institution and you see a lot of the cases, the treatments, what works, what doesn't work. Tell us what you're seeing at UCLA and how representative is what you're seeing at UCLA for the rest of the nation, the rest of the world, and how is it similar?
So the process is similar worldwide. There doesn't seem to be any real significant geographic variation. The sequence, as everyone has learned, is particularly when there's a breakdown of the public health measures, the next thing that happens is 10 to 14 days later, there's an increase in the rate of positive tests. That is followed about 10 or 15 days later by an increase in hospitalizations, which then is followed some days later by an increase in ICU admissions, ventilator use, and other very drastic measures. And then finally, you see an increase in the death rate. That sequence reverses in the same order as public health measures begin to work again, or whatever the episode is, a holiday or whatever the event was that caused a lot of breakdown of the social measures. And locally here at UCLA, we saw a big peak in the early phase of the pandemic in April, and then another peak in mid to late July. And now we're at levels that are very low as they were early in April and late March. I would say our experience is not exactly typical because as an academic health system, we're often called upon to take the sickest patients, so patients in community hospitals or other hospitals where they are in need of a higher standard or level of care. We will take those patients and transfer, so we tend to have a sicker patient population group. But the sequence, the similarities, they're all pretty uniform, and that we've seen what everyone else has seen.
Mm-hmm. And Dr. Mazziotta, if you were to give us kind of your own view of a rank order of the most promising solutions or actions that need to be taken. So you've already alluded to a couple of them, but precautions taken by individuals, medical research, healthcare practices, government actions at a local level, national level, learnings from abroad. Give us your sense of the kind of most critical actions here and solutions.
Well, far and away, our rule locally and the rule that's worked best globally is you got to respect the science. You know, we learn more every day. So the answer today may not be the same as it will be in December. But you have to go with the best practices, the most accurate information, the most universally observed patterns, and use that effectively. As I said at the beginning, while there's no treatment or vaccine, the public health measures work. And we've seen that played out in different states and different countries in different ways. And we've seen whether they've been effective or not based on how they were enforced, how cooperative the society was that was asked to follow those rules. We've also learned to some degree better medical management practices, using pulse oximeters to detect when somebody is going to have a change in oxygenation, but they may not be aware of it. Delaying intubating patients as long as possible. And using, in really sick patients, using things like ECMO, the actual heart-lung machine type strategy, where instead of having the person's heart and lung oxygenate and circulate blood, you do that with a machine, and you do it as an alternative to using a ventilator when that reaches the end of its effectiveness. So there have been lessons learned, but it all comes down to the science, and every new fact that we learn, the better we'll be at managing this.
Mm-hmm. Good. And tell us now, if you would, what is your view about the likely outcomes here? When do you think we'll have a vaccine? There's just news this morning that AstraZeneca has delayed their vaccine, but when do you think practically we'll have a vaccine? When do you think it will be out there in sufficient volume to have a material impact, and how might that look different geographically?
So in terms of outcomes, there's 4 ways out of this. The first is a vaccine. So that's pretty easy to understand, but there are different types of vaccines. So we'll come back to that in a moment. The second would be an effective treatment, to take this disorder and make it something that you can tolerate, like a bad viral illness, but you don't have to be hospitalized, and it has a very low mortality rate. The third is herd immunity. So enough people have had it in the population that it can no longer spread, because the majority of people are already immune and they don't serve as a reservoir to spread it. And the final way is to figure out, either genetically or phenotypically, a way to identify people who are going to get very ill and need to be hospitalized. We don't have that information yet. We know that elderly and people with comorbidities, other illnesses, diabetes, heart disease, obesity. If we had a way to find that subpopulation and sequester them, we could open up the rest of society, because we knew they wouldn't become as seriously ill. In terms of other consequences, if you look back in time 100 years and you look at the Spanish flu, there are lessons there. That was a seasonal flu, and the component of it that occurred in the spring killed millions of people, but it was 5 times worse in the fall. It doesn't look like COVID is a seasonal phenomenon, unfortunately, or we would be and are still bracing for a second wave, not these ripples that we've seen from breakdowns of social distancing and other public health measures. The other thing that happened with the Spanish flu is years and sometimes decades out, there were neurological consequences that have been attributed to having had the flu and having had nervous system involvement, like Parkinson's disease. That's controversial, but it's possible that there may be longer term consequences. In terms of the vaccine, it's really unpredictable. I mean, you can watch the news every night and you'll get a different answer, and I don't have any great crystal ball on that one. But, the stopping yesterday evening of the AstraZeneca trial, hopefully it'll just be a temporary halt, and it will resume once it's understood what was the basis for the adverse reaction that occurred. So we'll have to see what happens there. I think that there are enough vaccine trials, we participate in many of them, that vaccines will emerge that are effective. And I was quite encouraged about the AstraZeneca trial, because the vaccine developed at Oxford University produced not only antibodies, which is one form of immunity to a virus, but also T-cell immunity, which is a different form. And in papers from Asia and Singapore, people had varying degrees of antibodies, but they had T-cell immunity. So a vaccine that produces both, which this did or does, hopefully has a better chance at producing more effective immunization to it. And there's no reason to think there's going to be geographic variations in this. It's all going to be about infection prevention and then ways to stop it through vaccines. Mm-hmm.
So we basically have gotten a kind of a quick snapshot look at where things stand with COVID-19. I'd like to now have a discussion about leadership here, about, what have been the things that have worked and what are the things that haven't worked, and kind of post-mortem style about what should be done for the future. And let me just start out at a macro level here, because it's interesting. You've already made a couple of comments. You said COVID-19 is a manageable issue. You've also said you have to have respect for the science. if you take those two comments and reconcile them in the US with the current statistics we've got, the number of cases, the number of deaths, is this in essence kind of a condemnation of leadership here? Or do you say, you know what, this is broader than just leadership. There's a variety of other things that are going on here. What is your view at a macro level about leadership against the results that we're seeing?
Yeah, I think it's a mix. First of all, you put a pandemic into a system that has a fragmented healthcare system. It isn't sewn together seamlessly. And when you put a disaster on top of a system that isn't designed for it, you reveal all the flaws all at once. So supply chain breakdown and differences in the application of public health measures and you name it happens. So I think what we saw at the beginning was all of this uncoordinated effort, internal competition, people vying to get supplies, no coordination, and then just some unfortunate events like New York. I mean, New York was inundated so fast, they were overwhelmed, couldn't keep up with the patients, and that's when you get these high numbers of fatalities. Northern Italy, Brazil, New York City, that's what the outcome is. If you can not be overwhelmed, if you can have attention to detail for every patient, you won't have that kind of numbers as an outcome. Mm-hmm. And it's the same illness, right? It's the same illness. Mm-hmm. It does depend on the density of how people live and travel. It does depend on how old the segments of the population are. But if you're overwhelmed, the hospital simply cannot deliver the detailed care that's required to take care of really sick people.
Mm-hmm. Okay, very, very helpful. On the fragmented healthcare system, is there an argument in a leadership learning that, we need a less fragmented system? Or would you say in business, we always kind of look at this centralization versus decentralization, and you say, listen, there's offsetting benefits. Sometimes when you have what you may call fragmentation or decentralization or entrepreneurial efforts, you're getting other benefits that help society, help communities. Do you feel that way? Or you say, you know what, that's kind of a cop-out. You can't tolerate fragmentation in this environment.
You don't want to lose entrepreneurialism in healthcare because it does drive innovation, it does drive advances. But at the same time, you have to be able to deliver in a crisis, right? We'll use Los Angeles as a microcosm of that. So healthcare in Los Angeles is highly fragmented, highly competitive, all the things you know and see. It can be profitable or not. And there aren't many businesses where there's profitability competition, but it's also a basic human right. So we have to pay attention to that. And as a public university, we really have to pay attention to that. So we have a system that is a blend of decentralized and some centralized regulatory functions. And how do you glue that together to make it work? Well, I don't think it happens by having a group of people sit in a room in Washington and do it. It has to work all the way from the federal government to the state government, to the regional governments, to the cities, and then to the networks of health systems within those cities. During the pandemic, there's a group called the Hospital Association of Southern California, and that was a regular meeting. How are we going to balance the patient load? How are we going to share PPE? How are we going to deal with how much remdesivir is available? Who's going to take the sickest patients? Every day, arch enemies, competitors working together to solve a public health crisis. That's the mentality that has to carry forward, and it has to be down through all these different layers. It can't just be mandated from above because it won't work. There's all these different systems. There's the Veterans Administration system. There's large for-profit healthcare organizations. There's academic health centers, and each contributes a different piece to it. So it needs a really innovative way to put it together. But in a time of a crisis, there has to be a centralized command and control. when we face a crisis in the health system, we go to a very standardized approach. It's militaristic. We stand up a command center, and the command center is run in a military way. It's like the launch of a manned space program. Everyone's at their console. Everyone has a job. When we're all in the room together, everybody has a vest on with their duty on the back, on their function. And we may meet every 4 hours or every 8 hours or every 12 hours. And round the clock, 24/7, there's an incident commander, and every aspect is reviewed every time. And if there's a problem, someone says, I'll get back with the answer to that. And that's what you have to do. You have to make high-risk decisions with ambiguous or incomplete data. And we do that every day in medicine. But here we're doing it on a pandemic scale. So it requires rigor, requires science, and it requires attention to detail, even in the chaos of the moment.
Yeah. So on a root cause basis, why wasn't there contingency planning? Should there have been contingency planning from a leadership standpoint? Businesses do this in case there's an emergency, but at a national, state, local level, shouldn't there have been a contingency plan for an environment like this that then would have driven the actions you're talking about? Or that is orthogonal to everything that we are as a nation?
No, there should have been a plan. I'll be clear about that. I think there should have been a plan. There should have been stockpiles of PPE. Every article you read, every news story you hear, one of the two most common words these days is unprecedented, right? It's not unprecedented. This is that you could anticipate this. We got close with SARS. We got close with MERS. We got not so close with Ebola. But these things will happen. There was the pandemic of the Spanish flu in 1918. We've been very fortunate for 102 years, but here it is. And this will happen again. So you have to maintain that vigilance of the fact that this will happen, and you have to have the networks, the systems, the supplies, the workforce to be able to ramp it up when you need it. And then you need a way to react to the dynamic nature of it, right? So in a highly organized society, when New York started to fail, everything should have gone to New York. Mm-hmm. People, the equipment, the ventilators, and then moved to the next place, and then moved to the next place. Everyone maintains their baseline, but the hot spots get special attention and extra equipment, people, and supplies. That didn't happen. It happened on a voluntary basis. I mean, the University of California sent staff to New York. They sent staff to the Navajo Nation and other places that were hit hard or overwhelmed. But it was ad hoc. It wasn't planned.
Yeah. So with everything that we've seen here in the U.S. that has been kind of some failures, learnings from New York and learnings from abroad. Our last series, we had people talk about practices in South Korea, in Singapore, and in Taiwan with contact tracing. They talked about a different culture, et cetera. But with all of these learnings here in the US and abroad, is there any sign that there is changes in how we're operating, or we're not seeing the changes that need to happen?
Well, let's talk about what we learned from others. So I think that, I think a good rule in almost any business is learn from people who've already been through it, right? So early on, in very early March, we organized a Zoom meeting with our sister medical school in Zhejiang, China, and they had just had sent a contingent of 40 physicians to Wuhan, and they had just gotten back into Zhejiang. And so the screens came up, and there was 50 or so of them, and there was 20 or so of us. And things had already started to settle down and calm down in that part of China at the time. And the most glaring thing right off the bat was every one of them had a mask on, and not one of us did, right? So right off the bat, you could see that there was a fundamental difference in just how people were reacting to it. We learned a lot from those conversations. we asked them, what do you see now in New York and in Italy? That's when Italy was really in desperate straits. What is your advice for us? Because we've seen what happened in China. We're seeing what's happening in Europe. We're next. And they said, well, the people aren't obeying the rules, right? We said, so how did you apply the rules? And they said, well, it's very simple. If someone tested positive, that person and everyone around them, everyone we could contact trace was in quarantine, not honor system quarantine. They were in a state-run facility with guards. Food was delivered and they didn't come out for 14 days. And then they had to have consecutive negative tests. Mm-hmm. That's how you stop it. And basically that's what they told us over and over again. They told us some medical things, some subtle information that we might not otherwise have known. But basically they said public health measures to the extreme that society will tolerate. Yeah. And, we've seen that play out.
Do you view those practices are in the art of the possible for the U.S., knowing our unique culture, the rights of individuals, the entrepreneurial spirit, a highly individualistic culture in the U.S.? Do you think it's really practical to assume that could happen here? I.e., you said it's a crisis, you need to be in a different mode, or you know what, that's a different model, a different culture, and we can only adapt to some part of that, but we can never get fully to that model.
Yes, I think that we're a different culture, and that's not going to happen voluntarily. If the death rate from COVID was 12%, it would have happened out of fear, right? People would have voluntarily said, I'm not going to die from this. I am going to follow every rule there is. So initially, when it was unclear how serious it was going to be, people were pretty good about the rules. Look at California. We did very well in the early months of it. But people get real tired of it, right? So maintaining that level of vigilance and that level of compliance is not something that is easy to maintain. The United States is great at responding. Hurricane, response. Tornado, response. Fire, response. Prevention, not so good. So I think that's a lesson learned here, that we have to be able to look forward, make the commitment, have the stockpiles, plan. And it's not to say that these things weren't done. There have been many plans developed for pandemics by the federal government, by states and other things. Mm-hmm. But people get lax with it because 100 years is a long time to go between events, but it's going to happen. It's not unprecedented.
Yeah. How would you make that case as a leader to have that compliance? I mean, in a democratic environment where we do like to honor people's rights to live their lives as they will, what would have been the most effective way, short of a high death rate, to really get people to do what they need to?
Yeah, I think it depends in some part on the respect that the society has for the science, right? We still have people in our country who think it's a hoax, who thinks it's some sort of fraud. I mean, granted, that's a minor sub part of the population, but I think that seeing what happened in New York, I was surprised that people would not adopt and be compliant after seeing that. It was somewhere else. It's not my problem, but nevertheless, that was shocking, right? And that was on the news night after night after night. And that didn't do it. So unless it's brought home to you, either with a friend or a family member, or your community is one of the hotspots that takes off, it's very hard in a permissive society to get compliance at the level needed to suppress something like this.
Mm-hmm. Let me ask you the number one. We've gotten a lot of questions already have come in on Slido, and I think you've partially answered the first, but I want to confirm I've got your answer right here. How concerned are you that actions taken by the current U.S. administration may be used to distort and minimize the counts of COVID-19 cases and COVID-19 deaths?
Well, I hadn't thought about that, but I can tell you the numbers we report are reflected upward through the county, through the state. It's all seems valid and reasonable. And don't question the data in terms of the hospitalizations, positivity rates, deaths. I mean, I think that's collected locally and summed up as it goes up the chain.
Yep. And in terms of leadership actions by the current administration, I know we're getting a little political here, but I'm trying to understand from a leadership standpoint, would many of the kind of really bad outcomes we're seeing, could those have been averted if at a national level with the current administration, there was more decisive actions, more respect for the science, as you've stated earlier?
Well, yeah, whenever you respect the science and play by the rules, you're going to have a better outcome, but you still can be overwhelmed. New York didn't have a chance because it took off before they really had opportunity to do a lot of these things. And they're in a high density mass transit situation with a considerable number of people in assisted living and nursing homes and those kinds of things. And that's just a recipe for disaster. And that's what happened. And hard as they worked, they still couldn't get out of it until it burned itself out through the population.
Mm-hmm. Good. Next set of questions here is about the role of technology. So one of the most popular questions here is, how effective do you think that telehealth is as a viable solution to limiting COVID cases and expanding access to healthcare to vulnerable populations?
So that's an excellent question. We started to ramp up telehealth in February as we started planning for what was coming our way. In January of this year, we did 900 telehealth consultations. 900. Mm-hmm. In May, we did 85,000.
Wow.
So, and that was a huge effort on the part of our IT people and training and teaching patients how to interact with the interfaces and all the other things, but it worked. And that's not to say we could take care of every patient by telehealth, but the ones that didn't need to actually come in, especially in the early days of this, they didn't come in. We saw them that way. And now, as you look out this many months, we're still doing significantly more telehealth than we ever did before. But we're doing many more inpatient visits, et cetera, where people really need exams or procedures or other things. Mm-hmm. And so telehealth is here to stay. I think it's going to be extremely effective. We've used it for over a decade to take care of stroke patients where we have experts here, but they don't have them in rural or community locations. We've used robots to take care of people in ICUs. And something like mental health is ideally suited to telemedicine strategies. So you have rural communities, people have behavioral health or mental health illnesses. Why not connect with experts in more urban areas or where there are more healthcare workers that specialize in those disorders? And we can make that deliverable easily. Mm-hmm. I think the final part is just convenience. I mean, here in LA, you can't get anywhere when there's not a pandemic going on, right? So why would I drive 10 miles, which could be an hour, when I can click on my screen and get an update on what's happening with my health on certain topics that don't require an in-person exam?
Yep. What about other types of technology, contact tracing as an example, or the use of data and AI for predictive diagnostic capabilities? Are you bullish on those or not really?
Very much so. I think that, again, respecting the science, studying the data, we now in the University of California, we have 6 medical campuses. We're one of them. And they're all linked together through a federated set of databases. And so there's 16 million people. So we can look at all the people that have diabetes throughout the entire state that are cared for in the UC system. And you get to see how much variation there is in the treatment, as opposed to saying, okay, this is the best practice for this type of patient with this stage of diabetes. We should all be doing it this way. And those kinds of things can be very useful. They can reduce the costs of healthcare. They can optimize the outcomes in healthcare. We've used various types of data analytics to predict worsening trends in the hospitals using meteorological forecasting tools. This set of metrics over this period of time portends this bad thing is going to happen, or this person's going to end up in an ICU or have a cardiac arrest. Let's intervene 2 days before that happens rather than as it's happening. So these tools are very effective and have proven to be important in improving the outcomes.
Yeah, and to your point earlier about the U.S. having a fairly fragmented healthcare system and being decentralized and all that, do these technology solutions do better when you have scale? So contact tracing, when you can really get compliance across a large population, or in the case of healthcare diagnostics, you need large data sets. Do you need scale and standardization, or no, the opposite? Entrepreneurial efforts here will really create lots of great solutions all over, and you don't need the scale.
You need both. So you need the entrepreneurial efforts to generate the new ideas, and you need the scale to have the magnitude of data to actually prove that what you're seeing is valid and reproducible.
Yeah. So changes in data privacy laws, would you say that that is a necessary evil here to, create more of an environment where data can be shared to improve diagnostic outcomes?
No, I don't think you have to have one or the other. I think there are excellent ways to protect privacy but share data. I think the sharing of health data is something that must be done with the utmost vigilance and scrutiny, and it has to be done in a just way, right? My rule on that is no data for dollars. We don't sell data. Mm-hmm. Data in collaborations where we never actually let it leave our shop, but we collaborate with our data, has to benefit the people whose data that is, right? So it has to benefit our patients as well as the rest of the world if something meaningful is observed. Mm-hmm. But that's what I mean by saying data sharing in healthcare has to be just. It has to pay attention to the people whose data originated from them, and it should be used to improve their health first and everybody else's next.
Yeah. To do that, do you think we need change in legislation so that you still can get data for the right purposes, not for monetization, but for improving public health?
I think it'll be a mix of regulatory aspects and ingenious ways of sharing data with encryption and other mathematical and analytic techniques that don't necessarily reveal the source.
Okay, excellent. Several other questions here. Again, quite a few coming in. Are you concerned about healthcare worker burnout in response to COVID-19? How is UCLA addressing this?
Very good question, a very important issue. Today, this is day 193 for me of COVID, straight days. And for a lot of our people, they've been at it, not every consecutive day, but a lot of days. It's hard work. You're wearing a lot of equipment. Often the healthcare workers who are directly in the COVID wards and ICUs. It's hot, it's tiring, it's stressful. They worry about themselves, their families, etc. So we've had to do a lot of things to try to help mitigate that. Those have included enhanced mental health services, very clear directives about safety and protection, ways to supplement the things we can for the healthcare workers when we're able to, make it easier in the days when there were no supplies in the grocery stores, have groceries for them in the hospitals, let them have the groceries there. Generous donors have provided free meals and all kinds of things. It doesn't detract from how hard the work is and how stressful it is. If you were to come to the hospital, you see people outside in between shifts, and they got marks on their face from goggles. Their hair is wet from sweating, and it's just hard work. And this is not a sprint. This is a marathon. So we have to now build in ways to rotate, periods of rest and periods to get away from this. It's made worse by the fact that there are child care and elder care issues with no schools and all the other things that are happening. And so it's an ongoing challenge that we're very much concerned about, worried about, working on, and it's something that we have to be successful with.
Mm-hmm. Good. Another question. What evidence exists of repeated infections of the same patients of mutated strains? Is herd immunity really still considered a valid method to tackle COVID?
So I'm a neurologist, not an infectious disease expert, but I have only heard of a handful of people with reinfections. That doesn't mean it's not happening. There was a couple of papers recently in the last week that shows that the mutation of the virus has been rather slow. So that's encouraging. That means that a vaccine developed against what the virus looked like 6 months ago is likely to still be effective on a vaccine that's given 6 months from now. But the rules of this game have not been sorted out yet. So based on past experiences and the way immunity works, that's the expectation. But we'll have to see. We have to do the proper trials. They have to have the appropriate safety built in. And you saw with the AstraZeneca trial, that trial was stopped, appropriately so. We'll see what that story plays out to be. But that's what you have to do. There's no shortcut.
Yep. Another question here. We've always known about health disparities in communities of color. What efforts, what strategies can be used to improve outcomes? I guess the questioner is asking really in general, but also related to COVID-19.
Yeah, so with respect to COVID-19, again, like with everything, when you have a crisis or a disaster, the flaws really come out, right? So here's another major flaw in our healthcare system is that healthcare is not distributed equally. And that's a fundamental, as I said earlier on, healthcare is a fundamental right. So we have to, as a society, make that happen. Mm-hmm. With COVID-19, I think there are a couple of issues that have to be understood. There's certainly the social justice component. I'll come back to that. There's also the potential genetic component. So we've all seen on the news early on, particularly, the family who goes to the wedding or the funeral and 5 people get really sick and 3 of them die and they're all related and their spouses are fine, right? That just screams genetics. So one thing that has to be understood is, are there different genetic susceptibilities to COVID based on race or gene composition or a whole myriad of other things? That'll ultimately be learned, but I don't think we can just dismiss that. That could be part of the puzzle, or not. We'll see. If it's not, then it really lands on the fact that we have different populations who live in different densities. They use mass transit. They may not be able to work remotely. They have underlying healthcare conditions because they are underserved in the healthcare market. And obesity, hypertension, diabetes, cardiac disease are all more prevalent in those populations, and they get sicker. They die at a higher rate. So that's just wrong. That's something that healthcare has to solve. We can't solve genetic issues yet, but we certainly should solve the societal issues that produce outcomes that are this widely different.
Good. Very helpful. A couple more questions, and then I want to do a summary here. Will UCLA Health pilot the vaccine? If so, what is expected time frame that will roll out? How will this impact the medical staff and allied staff in health?
So right now we're involved in vaccine trials, but until there is a validated and safe vaccine, we haven't made decisions about how it would be rolled out. We would certainly want to be at the forefront of delivering that vaccine to not only our own healthcare workers, but all of our patients, and facilitating in any way possible the rest of the population. Okay.
Good. Another one, agree or disagree. FDA decisions regarding EUA are primarily made by career scientists? Should the scientific community be doing more to de-escalate politicization?
Yeah, so this is not a yes or no, although that's how it was posed question. I think science seeks to find the truth, right?
Mm-hmm.
That's why it's called research. Research, look again until it's reproducible over and over and over again. And when that happens, things that were myths and fallacies are eliminated and facts are put in place. That's science.
Mm-hmm.
Politics isn't that way. Other things aren't that way. I think if we stick true to the nature of science and the fundamental scientific principle, we'll come out of this fine. And anything that further enhances the use of rigor and science to answer these kinds of questions, I would support.
Yep. Dr. Mazziotta, let me ask you a broader question here, because it's been very interesting kind of hearing some of the piece parts that are required to get good outcomes. Respect the science to a certain degree, have a plan, some standardization, some scale, et cetera. If you looked at it on a scale of 1 to 10, 10 being a great outcome, and maybe 10 being outcomes that we're seeing in parts of Asia right now with COVID-19 and healthcare, and lack of disparity of outcomes, and 1 being horrible outcomes. Where are we right now? And where do you think practically, knowing how the nation is kind of constructed and the culture and everything else, where could we get on a scale of 1 to 10?
Well, we could get way high in that scale if we came together as an organized society. It's hard to do given the nature and culture of our population. But if you look at states that did well, if you look at counties that did well, they did so because the leadership made the case and people listened. That was true in 1918 as well. There were wide differences in outcomes in different cities simply based on what people were told, how clearly it was delivered, how concerned the population was about the adverse outcomes. And, you see the spectrum of outcomes in the United States, from California, which has done quite well, and other states that have done quite well, to places that through their own lack of enforcement and focus on the science, to just bad luck, have not done well.
Yep. Good. Let me ask you a final question, and then I want to kind of give my takeaways I got from you and give you a chance to upgrade them. Fast forward for us. 1 year from now, or roughly whatever time frame when we're kind of getting into vaccines and solutions, et cetera, what will things look like? Best guess a year from now? And then if you were to fast forward 5 years from now, because we've talked about a lot of broader systemic issues in healthcare and leadership, et cetera, where should we be in 5 years? Give us that kind of future look in both cases.
So 1 year, I'll give you my moderately optimistic 1 year look. 1 year, we have a vaccine. We have certain parts of the population that have also reached herd immunity through the rippling of outbreaks and suppression. And healthcare workers have all been immunized, and most of the vulnerable population have been immunized, and ever increasing numbers of the general population have been immunized. And we're starting to see the end of the process. 5 years from now, so this is over, the pandemic's over. We may see some long-term sequelae, medical sequelae of the pandemic. We don't know that. It might be 10 years. The nature of healthcare is drastically changed through a variety of different outcomes. 1, the need to work together. 2, the disparities that have been even more grossly revealed. The technology advances that have been necessitated by the pandemic. The nature of the organization of medicine will be changed. I told the faculty in late February of the medical school, I said, this is our moment. And the medical profession and biomedical science have to stand up now and deliver, because the world is looking to us. So you have to stand up and deliver. But from this day forward, medicine will never be the same, ever. And we're going to see everything change: how we're paid, how we work together, health systems, government regulations, electronic and technological advances. It will never be the same. So enjoy this last time we're sitting together in an auditorium, because it's not going to happen again.
Fascinating. Let me do this. I've tried to take a couple of notes of the biggest takeaways that I got from our hour together. I want to share those with you, and I want to give you a chance to upgrade them, or if you have any parting messages here. I basically got 6 takeaways from what you shared tonight. Number one, that the COVID-19 situation is a manageable issue, but you have to respect the science as part of the solution. Those are kind of the top 2 things I got. The next one is that you need a plan. It sounds kind of basic, but we as a nation, and maybe as healthcare providers and a bunch of others, have been in a reactive mode, and kind of shame on us as leaders for not having a plan and instead kind of focusing all of our effort on reacting. Fourth issue is there's got to be a fundamental look at the structure of what we're doing. Are we too decentralized? Are we too fragmented? Are we at the right balance of kind of entrepreneurial spirit and individualism against kind of community activity, scale-oriented activity? The 5th item I got was that technology is key. Technology does have a big role to play in access for underserved communities, in access for ongoing health care, in better outcomes, et cetera. And then the final message I got from you on a much more aspirational and a assuring note is we can score high on the scale of 1 to 10. Don't despair, notwithstanding, candidly a lot of bad outcomes to date, that don't despair. This is our moment. And from this day forward, you said, medicine may never be the same, and maybe we're going to find leadership is not going to be the same. But don't despair. There is a bigger aspiration here. We will get better on a lot of these things. Tell me what upgrades you've got on any of those takeaways, and if not, any parting thoughts you've got.
I think those are key points. I'm not going to edit them. I'm not going to upgrade them. I'm going to leave them as they are. So I appreciate that. I would have to say that one of the great lessons that I learned throughout all this is how unbelievably responsive, collaborative, committed the whole society becomes in the time of this kind of crisis. Now, you may not see that on the news every night, but I can tell you, when we needed PPE, I called CEOs of companies everywhere. They delivered. We needed money. I called philanthropists. They delivered. I mean, no matter what it was, I talked to people who, we never otherwise would interact, and it was whatever we can do. And in return, now that we're trying to open other industries and businesses, we're trying to repay. We're trying to provide advice and infectious disease control and other things to entertainment and agriculture and school systems and all these different components. But it has been a coming together of sectors and people and circumstances that would not have happened without some kind of crisis of this magnitude. And I've just been totally impressed by that willingness and openness and generosity, and also by the commitment and dedication and courage of the people that work for us in the health system at UCLA.
Wow, that is great. Let me just say a thank you at the end here. Dr. Mazziotta, I just want to thank you. It's very clear in 1 hour's time, you've thought about these issues in a lot of detail, and it's impressive to see the thoughtfulness about the medicine, about public health, about leadership. It's not a surprise that you are leading with your colleagues a great health institution that is having notable impact. I want to thank you for also the sense of optimism amidst what feels like a really bad environment, because it's an essential part of leadership. I want to thank the Geffen School, who's been a very big supporter of this event, specifically tonight. My colleagues at Anderson, you've helped all of us on really thinking about leadership, and I'm just very encouraged with all of this partnership. So a huge thank you for the insights. Our best, again, to you and your colleagues for doing the important work that you're doing. Thank you.
Thank you, Terry. Tony.
Good.